Dana Miller presents the 9th Annual Obesity Conference, a practical look at obesity, diabetes, and current strategies. Featuring Andrew Storm, MD, A Call to Action, Pediatric and Adolescent Obesity.
Miraculously, Dr. Storm in the last 45 minutes has gone through a pediatric residency and become a pediatric endocrinologist and a weight management specialist. And so he's kindly stepping in for one of his colleagues. He's going to be talking to us about pediatric and adolescent obesity.
Yeah, I've been in training for the past 10 years, actually, since I graduated from Jefferson down the street. So my wife would be furious if I did that. But again, thanks so much for the opportunity to talk about this. I knew beforehand that this was going to come afterwards. And so this is intentionally a little bit shorter because I knew we'd have a lot to talk about with the endobariatric stuff. There's always questions, and I think that's great. So that we'll definitely finish on time. No worries about that. Get you out to the beautiful Philadelphia night skyline. This talk, I intentionally titled it A Call to Action because I think you can't talk about obesity and you can't have a conference about obesity without talking about pediatric obesity and the impact that it has on adults. How many practitioners here deal with children? You don't have to be a pediatrician, but you have children in your practice, yeah. So really, hats off to you. And this actually is what gets me out of bed every day. This talk makes me furious. And this is what really gives me the energy. The procedures are exciting, the new techniques and technologies are exciting, but making a difference here in this realm is one thing that really excites me. And the neat thing about gastroenterology specifically is that there are not, pediatric gastroenterologists tend to be very non-invasive, which I think is great, and it's what I would want for my kids. But when invasive things are needed, kids often come to adults in some things. So in bariatric surgery, there's very few pediatric-specific bariatric surgeons out there. They're usually coming to adult surgeons. It's similar in advanced endoscopy, therapeutic endoscopy. If a kid needs an ERCP, they'll generally speaking, outside of maybe one or two institutions across the country, they'll come to see one of us in adult medicine. And so it's the same in endobariatrics. We're seeing increasingly a number of children that are presenting for these procedures. And it's something that needs to be studied, and I think potentially a great tool for kids, which we'll talk about briefly. So no disclosures again to talk about specifically. We'll discuss the burden of obesity in pediatrics in our child population in the US. Talk about the role of prevention, which is clearly paramount in this population. Discuss some about the treatment of obesity in pediatrics, which is really wanting, as is most things outside of cancer treatment in pediatrics. We'll talk about lifestyle, medications, and procedures, and then a little bit about future areas of research interest that I think we all need to work on. So finally, I do want it to make you a little angry. Maybe not angry, but inspired. I think this is something that we need to take seriously, and this again is kind of the fire in my belly when I'm thinking about treating obesity. So the Lancet published this great study, the Global Burden of Disease study. It was a follow-up from a previous report that they had published showing that back in 1990, and we still struggle with this today, but childhood underweight was really the burden of disease across the entire globe. That has fortunately, thank God, we've made huge improvements in nutrition in third world countries, and so that's moved down to 8. It's still a problem, don't get me wrong. We still have a lot of work to do, but that has moved in the right direction. What's moved in the wrong direction, and maybe it should be surprising to you, is that high body mass index and associated comorbidities has moved from number 10 up to number 6. And the trend, if we had a follow-up study today, I bet it would be quite a bit higher. And so this is clearly becoming the issue to address in the world, let alone the United States. We know from previous speakers this weekend that the obesity epidemic in America is everywhere. More than a third of the US is clinically obese with a BMI over 30. That's a 4% increase from now, just from 2015. There is unfortunately a very disproportionate effect on minorities. Half of African Americans in the US, nearly half of the Hispanic population in the US, and there are a lot of reasons for that. Of course, obesity as we've talked about at length, is associated with a lot of comorbid disease that means we need to take it seriously and treat it as a medical disease. So what's the big deal with pediatric obesity? And I hope to convince you of what the big deal is. It's tripled in 4 decades, and it's less impressive than the adult obesity statistics, but still, to have tripled in 4 decades to 11.3% says something. Kids are pretty good at protecting themselves. They're pretty good survivors, and they're pretty healthy. You know, they have the youngest cells, their stem cells are young, and they do well with disease just in general. But something in our society, something about our nature, their environment, is allowing things here to progress and to move out of generally healthfulness that we see in kids to an unhealthy state. And so this is defined in kids as a BMI over the 95th percentile, specifically obesity in kids. We can't use the typical BMI percentages, as you all know, who practice pediatric medicine and obesity medicine. So we're seeing diseases that, you know, my grandfather never would have thought that we'd see. He was a primary care doctor who gave some of the first polio vaccines in southern central Pennsylvania. And obesity-associated sleep apnea, non-alcoholic fatty liver disease, and at Mayo Clinic, liver transplants for teenagers because they've got fatty liver disease. Type 2 diabetes, just things you never would have thought. I think they would laugh if they knew this was happening. Laugh or cry. So this is a video. It's dramatic, and it's meant to catch your attention. It's like a public safety announcement, so there's no question about it that it's a little bit dramatic in its message, but I think it does give a couple of, sends some messages that I think are important for all of us. It's from a group out of Atlanta that really is great. They have some super resources that I use for my pediatric patients, Strong for Life. And so I'll just show this quick video.
All right, what do we got?
Just came in. Heart attack. 5'9", 300 pounds, 32 years old.
How the hell does that happen?
Can I get a, Could be developing diabetes. You have to make a change. Oh, yeah.
You're graduating! Watch TV. You won't even have to leave.
You can't do this.
Yes, can I get a...
Yeah, no, deep dish.
You have to make a change. Good job, Jim. You got an A+.
Here are your fries, sweetie.
I still can't believe you give this child french fries.
I know, but it's the only thing that'll make him stop.
So it's dramatized, but there are some messages there that I think are important for all of us to realize and recognize. So all of these things that our predecessors in healthcare have done to improve the life expectancy in the United States, there's now evidence that that's being reversed. There's evidence that over our lifetimes, and certainly over our children's lifetimes, we're actually going to see a decline in life expectancy, and that's terrifying to me. So we've made all these great bounds and leaps in medicine in saving lives with polio vaccines and the age of vaccination, and now with heart disease and cancer treatment, and we're probably undoing it with obesity, which is sad. The problem really has been known for quite some time in children. Kids that are obese will have a lot of changes that were recognized 50 to 100 years ago. Earlier breast development, pubarchy, and menarche occur earlier when BMI is over the 85th percentile. And we're seeing big changes in sleep hygiene, which may contribute to the increasing diagnosis of psychiatric disease in children. Obstructive sleep apnea increases 12% for 1 BMI point over the mean for age and gender. This results in excessive daytime sleepiness and inattention. Orthopedic injuries are increased in these children, and diabetes has really become a disease. Type 2 diabetes has become a disease that you never saw in kids, which is now fairly prevalent. So if you were born in 2000, this is another terrifying statistic. I don't mean to be so downer, but if you were born in 2000, if your kiddo was born in 2000, their lifetime risk of diabetes, if they're a male Hispanic child, their risk is actually approaching 50%. It's even higher in the female category. And this should be terrifying to us as a society, certainly for those of us that are parents and caretakers of young ones. Furthermore, and this is one of the messages from the video, childhood obesity and behaviors learned in childhood do carry into adulthood. So a child who is obese, and particularly a child who is severely obese based on their percentile BMI, is definitely going to be in a higher category BMI, a class 3 and above obesity group when they move into adulthood. So 100% of kids that were above the 99th percentile had obesity, as defined as BMI 30 or greater, and the average was a BMI of 43. So these, again, just show that childhood obesity needs to be taken seriously, because it will become adulthood obesity that enters some of our realms. The cost is really staggering. So $147 billion spent on obesity in the US in 2009, just with direct healthcare costs. That's up from $85 billion in 2005, just again showing the trend, and it's predicted to be over $210 billion when the ball drops for 2018. That's in total more than $1.4 trillion in the U.S. in indirect costs when you consider in things like disability, anxiety, and psychiatric disease related to obesity, decreased productivity and missed work, lower socioeconomic status, and poorer employment opportunities available to folks who are obese. The cost is also able to be directly measured on a day-to-day basis in the hospital. So what are the most common indications for admission on the pediatric wards? Well, asthma and pneumonia. They're both going to cost the payer and the parents quite a bit more, at least $2,200 and $3,400 respectively for hospitalizations for these conditions. Appendicitis, a surgery, you're not surprised, I'm sure, to hear that a surgery is going to be more complicated and more costly in a child with obesity, with increased lengths of stay as well. So what is the cause? It probably, definitely multifactorial. Food deserts are a problem. I did a lot of my pediatric rotations up in North Philly at Einstein Hospital. Definitely a food desert up there. So access to good calories, not just calories, is an issue. And then to it's the kids who don't have a guarantee of having food on the table every night that are much more likely statistically to develop diabetes, but definitely obesity over their lifetime as well. Inadequate sleep, stress, type and timing of food, increasing evidence, as has been suggested earlier today, of some role of the microbiome, though chicken and egg discussion can be had there, and gastroenterologists are at the forefront of microbiome studies. Obesogen exposures, this is a kind of a hot topic in the press. Maybe something that our mom was exposed to before we were even born had a big impact on our future propensity for obesity. The environment and chemicals, I remember in college, everybody was handing out Nalgene bottles. Now it's practically a sin to get a Nalgene because of the BPA and estrogens that are leached into your water. I still use my Nalgene, but you're not supposed to. Things have changed, and we're becoming increasingly aware of those things in our environment. So what's the solution? The prevailing wisdom, and it's true to some extent, is that calories in need to be less than calories out. You cannot have a positive energy balance if you want to maintain or lose weight, and that restricted energy intake and modified lifestyle are really the foundation and cornerstone of weight loss and healthy weight. So that's true if only it were so easy. We know some things don't work. So Disney actually had a ride that was short-lived, but it kind of vilified what they thought to be behaviors, kind of sins that have led to obesity, snacker, lead bottom, and glutton. So this was a ride, I think, in Epcot that, again, was short-lived and protested and fortunately, I guess, is no longer in existence. There are also mainstream media films. This poster, you can see, what if Snow White was no longer beautiful and the Seven Dwarfs not so short? The movie didn't do well, but what we're telling our kids is that, boy, she's beautiful, and even though she has the same hair and skin and everything, boy, she's not. And why? Because she's shorter and rounder. And this doesn't work. This is bullying and doesn't work. So what are the goals of treatment when I see a child in clinic? We're going to do our best to develop healthy habits and lifestyle patterns through their adulthood. The goal there being that they carry this behavior into adulthood, that we're giving them tools to fish for their life and not just fish for the day. Improve the health and quality of their life, to improve their body composition now as children, again, to carry into adulthood, and then to prevent future adverse health consequences like the cancer, heart disease, that we know faces those with diabetes and obesity down the road, and then to improve their body image and self-esteem. So childhood obesity is defined differently. Again, those of you who practice in this realm know, but body mass index is not a super useful tool for the youngest of children. So we use percentiles of their BMI as compared to peers. These percentiles were based on data from the Midwest, not Minnesota, but I think Kansas data quite some time ago. So they're a little probably off of what averages would be today, but and probably why we're seeing so many more children who qualify as severe obesity rather than underweight. We see very few of these underweight or less than 5th percentile, which again comes with the caveat of not necessarily being a disease state, but just something to recognize. But healthy weight is the 5th through the 84th percentile, overweight is the 85th to 94th percentile, and then obesity is the 95th percentile and above, with severe obesity where we kind of think about class 3 obesity, class 2 and 3 obesity in adults. These would be the kiddos, which we'll talk about in a bit, that would qualify, for example, for bariatric surgery. So again, just childhood obesity is defined, and this is an important distinction. 120% of the 95th percentile, or an absolute BMI greater than 35 in an adolescent or preteen, is that kind of most severe category where we start thinking about the development of comorbidities even in childhood and the potential need for procedural interventions. So we always consider the differential. It's important to recognize that especially in kids, there are endocrinopathies and other things that can lead to disease, that can lead to obesity specifically. So if an overweight child is also following their growth curve over time for height, then they're probably having a nutritional origin of exogenous obesity. We still do testing in some of these just to make sure we're not missing something, but definitely if there's decreased linear growth, so they're falling off of their growth curve but gaining weight, we look for endocrinopathies, testing TSH, free T4, eventually dexamethasone suppression test, and 24-hour urine cortisol if it's indicated. If they have developmental delay, we think about syndromal obesity, and this starts to get outside of a lot of our comfort levels and realms, so we often refer to genetics, and those counselors are extremely helpful in recommending the testing and treatment that may be needed. In terms of looking for comorbidities, whenever I see an obese child in clinic, we kind of screen on the review of system for things that may also be occurring along with their obesity. Again, we normally wouldn't have thought of some of these things, but like the development of obstructive sleep apnea, if they're having a lot of daytime somnolence, loud snoring, or witnessed apnea, we'll always ask mom and dad about those things. Insulin resistance, the physical exam will pick up on acanthosis nigricans, skin pigmenting, and skin tags, which can be a sign of insulin resistance, early or full-blown diabetes. Headaches and facial numbness can be a sign of pseudotumor cerebri, classically in a young woman with obesity. Polyuria, polydipsia, fatigue, and nocturia diabetes. Again, none of these things are surprising to you, I suspect. So in taking a history, and this is an important slide, it's different, our counseling differs kind of based on the age of the child presenting to us. So in a toddler, it's really all about the parents, and I think someone had talked about this earlier today, but we have to focus on the parents' behavior and the family's behavior, because that's usually the explanation. In a toddler that's age 1 to 4, we make sure that they have access to active play, that they've got plenty of opportunities to be moving, that they're not getting really any screen time to very minimal screen time at this age, and that the parents are role models both in activity, screen time, meal time. Make sure that food is not being used as a reward. So that video showed, when he got a question right at school, he got a piece of candy from his teacher. Make sure that we're not using food specifically as a reward, because it teaches us all behavior that we don't want to carry into adulthood if possible. And that you don't force a kid to eat, but that you keep diversity in diet. And all of the societies agree with this. Just put it on the plate, but let it be from there. Just to show them that there are other foods available, and that some of their food is going to be things that they don't like. In early childhood, that's where we start looking for things like bullying, potentially contributing to and making worse an obese state, but especially focusing on the family. Eating out, fast food and sugar sweetened beverages should be really at a bare minimum to none. And then in puberty, making sure that this is where we can really go crazy with the exercise, that they're exercising at least 60 minutes or more every day in total. We can talk about modifying their meals or packing their lunch, continuing to challenge them with vegetables and fruits that the parents just haven't given up and given the French fries, for example. Again, dramatized, but has some truth to it. And then making sure that we have some control on the sedentary time, video gaming and such, sleep duration, that they're getting plenty of sleep, especially early in life. So when do we start prevention? This is probably one of the most fascinating things to me. So prevention for childhood obesity, which leads to adult obesity, begins before a child's even born. It's really, to a surprising amount, all about mom. And I think I need to call my mom and tell her that after this, but it's all about mom. So there were 4 factors that this great paper from New England Journal showed, and then probability of developing obesity in a child. So number 1 was smoking. So smoking during pregnancy or not. Excessive gestational weight gain, which is linked to maternal diabetes and gestational diabetes, of course, or not. Breastfeeding for 12 months, and they had trouble separating out. I'm not saying that and certainly American Academy of Pediatrics does not say that you have to breastfeed for 12 months. Right now, the recommendation is 6, but they had trouble separating out a year versus less in the data. So they just said breastfeeding for 12 months or not, and less than 12 hours of sleep per day during infancy or more. And so these things, when combined, when all 4 were in the right position, so no smoking, no excess gestational weight loss, yes, breastfed, and yes, plenty of sleep, the probability of developing childhood obesity was extremely low, on the order of 4% or less. When all 4 were present, the risk of obesity was more than a quarter. What's that? Baby sleep. Baby sleep. You're right. So that's one thing that's right. This is not before they're born, obviously. You're right. Exactly right. The things that after they're born include the breastfeeding and sleep during infancy. That's right. So once the time for prevention has come and gone, and that's what a lot of the conference is focused on, as we move into treatment. And again, the cornerstone is lifestyle modification. We're starting to see more medicines. We'll talk about that in pediatrics in just a second. And then endoscopic procedures. This is obviously mostly in the experimental and kind of Hail Mary pass phase right now. And then surgical procedures, again, all the respect is deserved. These are very efficacious, have to be applied in kids specifically very cautiously for some reasons that we'll talk about as well. Nutritional and lifestyle therapy options, again, because of the amount of time I have with a kid and because I mostly exist in the procedural realm, we don't have a lot of time to go into diets, and so I leave that to my nutritionists and dietitians who do a great job with this. But different diets have pluses or minuses. Portion controlled is very well tolerated. It's useful in toddlers and young children, just teaching them kind of what a healthy portion is. It shows minimal to kind of small amounts of weight loss. There's carbohydrate reduced, which is not well adhered to, low glycemic index, which really doesn't have a lot of impact on weight loss, low fat, which is well tolerated and often well followed and well prescribed, but weight loss is really minimal. And then elimination diet, just meaning that we find those children who are struggling with obesity and discover, and man, I'm guilty of this too, they're having chicken nuggets every day for lunch, and trying to replace some of those foods. It's not an elimination diet like we talk about when we're talking about eosinophilic esophagitis and we're trying to get rid of a food allergy. It's an elimination of something that's just not healthy or ideal for kiddos. So lifestyle therapy, again, the cornerstone. We all know that and everyone's preaching it. But there seems to be a time or an age where we get to kind of adult level improvements in obesity. So it's kind of around the preteen years to teen years where lifestyle therapy, it's still the cornerstone and we still have to try it, but incremental benefits to BMI are lost, especially useful in young kids. Lifestyle therapy can really mean the difference between success or not, but we really start to see a waning of impact on BMI over time, specifically when kids get into their teenage years. So lifestyle therapy, I don't know, works really well for kids, but maybe not so well for teenagers, similar to adults. Best evidence lifestyle therapy should be intensive, age-appropriate, and culturally sensitive and family-centered. Decreased fast food and sugar-sweetened drinks are something almost everyone can apply and learn about. And just, riding on SEPTA here, there are ads for sugar-sweetened drinks in Philly, who's doing a great job of kind of taking to the public these ideas. Decreasing high fructose corn syrup, consuming whole fruits rather than juices. Essentially, getting rid of juices from a child's diet is appropriate in the United States today. Portion control, education, reducing saturated fat, and all of us could stand to increase daily fiber. If I did a colonoscopy for most people in the room, there's going to be diverticulosis, and we're going to suffer from diverticular disease because our fiber intake isn't enough and our colon's squeezing against dried out stool. Everyone can increase their fiber, and there's really no harm to doing that. Timely meals rather than grazing through the day, also important to consider. And then recognizing unhealthy eating cues. We've talked some about this, but screen time, increasingly an issue in today's day and age. Boredom and stress are all things we need to consider. So medications, this is, again, not my area of expertise, but is definitely important to the pediatric population. There are 5 FDA-approved weight loss medications for adults, and they include those listed here. It's been great to see them kind of come of age over my career so far. It's been great to see the number increase. It's been great to see some positive results and improvements in comorbid states. But in kids, we're sorely lacking. So only Orlistat is approved for pediatrics. So if you're under 16, you're kind of out of luck. And we certainly don't have any FDA guidance to allow us to use these other medications outside of this. So if you're age 12 to 16, we've got Orlistat, and that's kind of what we can offer you without stepping outside of the box. Phentermine alone is approved, I will admit, for 16 plus, but again, that has some shortcomings and issues. A lot of these medicines are never going to be approved for kids because of the increased suicidality and other issues, psychiatric issues that are seen increased in the pediatric population and young adult population. So we have some work to do there. Orlistat, again, the nice thing about having no disclosures is I can kind of say what I feel about some of these things. Orlistat inhibits gastrointestinal lipases. It's taken with each meal. There's no way I could take a medicine with every snack or meal that I have to consume throughout a day, so I can't expect that my 12-year-old patient is going to remember to carry these pills with him and take them with him at school. So there are major compliance issues with Orlistat. It prevents, as you all know, the triglyceride breakdown into fatty acids and monoglycerols that can be absorbed by the jejunum and ileum. It results in those triglycerides, therefore, being excreted in stool. So you may remember from about a decade ago, the Olestra potato chips, they left the market because of this. So may cause abdominal cramping and loose stools. Olestra inhibits the absorption of some vitamins. Vitamin A, D, E, and K, as you all know, are fat dependent to be absorbed. And so the issue with oily, basically greasy flatus, led to this product line's demise. And it's for the same reason your kids are not going to tolerate Orlistat. Furthermore, there are 3 randomized control studies of Orlistat in adolescents age 12 to 16. The net BMI loss to me is fairly unimpressive at 0.7 units on average. They almost uniformly reported increased abdominal pain and oily stools. The dropout at a year was 35%, just to note. And then unlike the data that was shown previously today in adult patients by the great talk earlier, there's no benefit to glucose or insulin levels seen in the pediatric patient. I don't know why, but they just don't respond as well. And maybe it's compliance, but it doesn't have the same benefits. So we're sorely lacking. All the societies, American Academy of Pediatrics and the endocrine societies all agree we need more pharmacotherapy options for kids. They need to be novel because the ones that are out there now for adults are probably not kid-friendly. And we need to avoid pharmacotherapy for overweight and reserve obesity really only for those that have failed lifestyle therapy. Furthermore, and this is different than the recommendation for adults, you're supposed to discontinue these medications if there's a minimal response after 12 weeks. And they define that as a 4% BMI reduction. Well, if you look at what's going to happen when a kid takes orlistat, they're never going to get anywhere near to a 4% BMI reduction. So the chances of this are pretty slim. So by these guidelines, you should really be discontinuing most of the patients that are started on orlistat in the pediatric group. So again, this is just a push. If you have any ear of a policymaker, this is something that needs to be pushed and needs to be a big emphasis of all the funding sources for research and pharmacotherapy going forward. In terms of endoscopic bariatrics, we just talked about it, so you all know it's my field, so I'm biased. It's minimally invasive, so it's low risk. It's somewhat reversible to completely reversible. Could it provide a bridge to adulthood? Could it help your children, patients, learn healthy habits that they can carry into adulthood? I think yes, and we'll have to show that in some data coming up. The bad side is insurance barriers, and there's just not a lot of money out there for treating pre-illness, which was another thing that was mentioned. So in a kid with obesity but no other issue, it's going to be an uphill battle to fight to get coverage for these sorts of things. Bariatric surgery, again, is highly, highly successful, but given the risk, especially in a child with so much life, so many life years ahead of them, it needs to be really considered only a last-ditch effort. It needs to be only considered in kids that have reached at least a Tanner 4 to 5 pubertal development. Same as adults, BMI greater than 40 or 35 with a severe comorbid illness should be considered for bariatric surgery. They need to have failed non-surgical therapy just like adults, and they need to have a demonstrated ability to adhere to a healthy diet and activity just like adults. Not that adult surgery shouldn't be performed in centers of excellence, but I think it's especially important that the surgeon be skilled in pediatric surgery and that they have backup for surgical care, surgical intensive care afterwards if they're performing these procedures. And there's multiple centers throughout the country that are performing bariatric surgery for kids. That said, and I'll come back to this point, but that said, retrospective data, so a big study in kids, so a big study like the Swedish study in adults is thousands of patients. A big study in kids is 11 patients. So this is a 5-center review. They had 11 patients that were less than 21 years old. They reported a great 34% total body weight loss at a year. All but one saw their diabetes stay in remission into adulthood, and all remained overweight. So it's not performed often, which is why I think we need to keep it in very much centers of excellence for pediatric bariatrics. The other thing to consider, like we had talked about with surgery for the group of folks with infertility, you really can't do bariatric surgery in someone who's going to be breastfeeding, who is pregnant, or who wants to be pregnant. And if you're going to do it in a female, basically at all, you need to have a frank discussion with them or their parents if they're under 18 about the very significant risk of infertility going forward because of nutritional effects and just intra-abdominal changes and adhesions and such that will impact fertility down the road. Again, don't want to take away from bariatric surgery, which is clearly the best and long-lasting weight loss treatment out there. The complication rate in kids is extremely low, even lower than adults when we consider only the serious adverse events of surgery. This 4% complication rate sounds significant, but it's actually mostly respiratory stuff, mostly complications from anesthesia in kids, particularly in kids that are overweight and have sleep apnea and such. So there were no known deaths reported I have yet to find a case report of at least an acute surgical death related to bariatric surgery in kids, which is great. So in summary, just to wrap things up, the obesity pandemic is affecting our youth. It's extremely costly, and it's probably going to reverse all the improvements we've seen in life expectancy in the US over the course of the next 50 years, which is, I think, something that should make everyone upset who works in healthcare. Prevention is key, even preconception. Lifestyle therapy still remains the cornerstone of management and probably always will. We need more medications and more procedural options that are less invasive. And then we need to keep bariatric surgery as an option really for Hail Mary kind of situations. That's it. Thank you very much.
This has been a Dana Miller Video Network presentation.